All right, people are still joining, so we're admitting them as they join.
All right, just let me know when to get started.
All right, well, if you're ready, I will introduce you. So again, welcome everyone. This is the first of two presentations being done today. And the first one is Emily Olson, and Emily is a licensed psychologist within the Child Development and Rehabilitation Center at OHSU. And she specializes in neuropsychological evaluation for children and adolescents with epilepsy and other medical conditions. And with that, Emily, it's all yours.
All right.
By the way, excuse me, kind of like we did yesterday, if you have questions, throw them in the chat. Jessica Beach and I will monitor those. Or, this is a pretty informal group. Feel free to unmute yourself and ask them directly to Emily. That works as well.
Okay, sounds good. Okay, man, I apologize. I'm really having quite a few technical issues with being on Zoom. Okay, hopefully you can see my slides now.
Cannot see them yet. And
okay.
Jess, do we need to make her a co-host?
She should be able to share, but let's see here.
That's true. Oh, there we go.
There we go.
Okay. Are we good?
Yeah.
All right.
If you want to go to there, perfect. All right.
Yay.
We're ready to go.
All right. Well, welcome everyone. It's nice to meet you virtually. And yes, please feel free to jump in and ask any questions. It's difficult for me to monitor the chat while I'm presenting, but please just jump in, or if someone can moderate the comments, that would be helpful. As Kevin mentioned, I am a psychologist at OHSU, and what it means to be a neuropsychologist, these are essentially psychologists who have specialized training in brain behavior relationships. And so what I do, I work primarily with a population of children and adolescents who are seen through our neurology departments. A large proportion of those individuals have some form of epilepsy, which is why I'm here today. And the bulk of my work involves doing evaluation of kind of cognitive skills, emotional functioning, looking at life functioning, academic functioning, and trying to understand how all of that intersects with epilepsy and other life factors. And so unlike some of my psychologist colleagues who do, the traditional sense of the word psychologist, we think of doing therapy and treatment. My work really focuses on doing these evaluations. And the whole point of the evaluation is really to understand the individual's strengths and weaknesses, and develop some strategies to help them out at school and otherwise. So I hope to touch on that during the course of my talk today. So first, I want to talk a little bit about how we think about brain development, because I think this is particularly relevant when we're trying to understand the impact of seizures on learning. So as you can see from this graph here, when we look at brain development, one aspect that we think about is kind of how neurons wire together and how neurons fire together. And a measure of that is what's called synaptogenesis. And that is really an indication of how neurons are making connections with each other. And as you might imagine, this becomes more specialized over the course of development. So you can see on this graph here from birth until adolescence, and it's an important caveat that brain development continues well past adolescence, which I'll touch on later. But we see that there's really robust rates of synaptogenesis in kind of early brain skills like our sensory and our motor skills, so things like vision, walking, those sorts of foundational skills. things like language, communication, and then higher order cognitive functions come online a little bit later. And the significance of this is really just to show you that the developing brain is kind of a moving target, if you will. There's a lot that can change and develop over time. And so anytime we're evaluating or testing cognitive functions, we really want to think about the brain as kind of an evolving and living thing. Another kind of foundational study I want to touch on is this is kind of an older study, but it was a landmark study at the time of publication. This study looked at kind of how different brain regions specialize over time. And here, instead of looking at synaptogenesis, the study looked at gray matter volume or gray matter density in the brain from a young age up until age 21. And they did these serial brain scans. And the bright areas here show that there's high levels of gray matter density when you're young. And those, interestingly, kind of become less robust over time as we get older. And you might be thinking, well, why is that the case? What we really have come to understand from this literature is that we see kind of a pruning back and a specialization of brain circuits. And so areas that we might have seen really high interconnectivity when we were younger have become more specialized over time. And so there's kind of this stereotypical pattern that happens with brain development, such that we see kind of brain maturation happening in more kind of rudimentary parts of the brain that are responsible for things like vision and sensory motor skills. And the most complex parts of the brain are really the ones that mature last. So thinking about temporal lobe and particularly the prefrontal cortex, which is the very front part of the brain. This is relevant when we think about the skills that are predictive for academic success from elementary school all throughout middle school, high school, and even into college. Executive function is one of those key skills that is supported by prefrontal brain function. And it's kind of a fancy way of describing the CEO or kind of the chief organizing officer of the brain. So these are skills like planning, organization, regulating not just our behavior, but our emotions, thinking about how to adapt our behavior for the context at hand. And as you might imagine, these are very important skills for things like learning, remembering to do your homework, planning for a term paper, those sorts of things, even skills outside of academic contexts. And the relevant takeaway here is that these skills develop well into early adulthood. So we used to think that the brain stopped developing at the end of adolescence, and we know that that's not the case. That we have changes that happen well into adulthood, and this area of the brain generally kind of reaches its peak or stops kind of showing maturational changes by about mid-20s. So when we think about the skills that are needed for life functioning, it's not surprising that we need a long period of time to be able to do these things well. These are just some more examples of how executive functions play out in life. Things like controlling impulses, being able to have proper initiation, so getting started on projects and persisting with them. Working memory is maybe a buzzword that you have heard. It really refers to the ability to kind of keep information in mind to be able to do something with it. And if you grew up without cell phones and remember having to remember phone numbers, I certainly do. Working memory is certainly something that you utilized at some point in your life. So this chart really kind of illustrates that executive functions start to come online as early as 3 years of age. And those things might look like, pretty rudimentary skills, but they are very important. So if you think about the game Simon Says, there's a lot of executive function skill happening there. So you need to be able to attend to important information, hold a rule in mind, and inhibit or exert impulse control when rules are violated or there's exceptions. So we see that all of those skills are online, usually by the age of 5 or 6. We also see, changes in memory that go along with some of these changes in executive function. And that is going to be something to think about later in this talk. In middle childhood, we see that executive function skills improve quite a bit, and they enable individuals not just to be able to grow their knowledge base of what they know, but engage in more complex problem solving to handle increased organizational demands. And those are really important skills for, elementary school and certainly the beginning of middle school. By adolescence, we see that in some respects, individuals have adult levels of some cognitive skills like working memory and attention. We see that abstract thought has really developed quite a bit from back when we were younger. We become quicker and more efficient at what we're doing. But there are quite a few things that continue to crystallize over time. One of them being weighing risk and reward when we're making decisions and figuring out, what is going to be a good decision in the immediate future may not serve us in the long term, and how to kind of balance those things is something that we see that it continues to be important through the mid-20s. When we think about seizures in the developing brain, I think it's important to recognize that there is no single cognitive pattern that is associated with epilepsy. There's so much variability. We know that epilepsy is such a diverse and complex set of medical there's so many diverse underlying medical factors that can go into seizures. And so it doesn't make sense to kind of make big generalizations. But some of the things that we want to think about in terms of what can contribute to cognitive skills and to learning are, some of the things that may predispose us to seizures in the first place. So genetic factors, structural differences in the brain. Those are certainly things we think about. We also want to think about kind of the severity of seizures, how often they're happening, how frequent they're happening, how long they last, how much recovery is needed between each one of those episodes to kind of return to what feels like baseline functioning. And then there are, of course, other factors that can play a role in our general health, how we're feeling, and therefore how we're thinking and performing in a daily life context. So medication side effects, the impact that health conditions can have on mental and emotional well-being, time away from activities, those sorts of things. All right. I want to pause there. Any questions before I keep going?
Nothing in the chat.
Okay. All right. So, as I mentioned, there is no single cognitive profile associated with epilepsy. So, I'm going to present a couple of patterns that we do see, but keep in mind that this is not everyone. And, this is kind of what we've learned from looking at large groups of people, but it doesn't apply to everyone. Every child is unique. When we think about seizures happening early in development, so generally before the age of 5, or even think younger, before the age of 3, we do say that there is a increased risk for changes in developmental progress. And so these would be things like not developing motor skills or learning to talk on time, or doing that in a slightly different way. They might be things like social skills, or self-help skills, so our adaptive skills, what we can do for ourselves. And so that's certainly a pattern that we can see. Early intervention is a wonderful resource that families of children up to age 3 are eligible for. After the age of 3, when children graduate from early intervention, they either do not need additional services, or they may need additional supports. And if they do need additional supports, they would kind of transition to what's called an early childhood special education plan. This is kind of the precursor of kind of an individualized education program plan. So it's kind of a alphabet soup, but I will explain that later. Um, but the short story is these services are available even before kindergarten. And if you are eligible for them, then they can really be of significant benefit if your child is having some of these developmental differences. Another pattern that we see in seizures for very young children, a lot of parents might worry about quote unquote regression, which, if we really think about what that means, regression means a loss of previously learned skills or knowledge. So your child was using specific words or doing specific skills, and now they're no longer demonstrating that skill. I want to be very, very careful to kind of differentiate that from simply just having slower progress in any one of these areas. Regression is certainly a rare phenomenon that we see, although there are some forms of or some epilepsy syndromes that are associated with specific regression, certainly in language. But they don't happen as frequently as, just differences in developmental progress. I put the link here for information about early intervention and early childhood education through Oregon.gov. The second kind of potential manifestation of neurocognitive difficulties that can be associated with epilepsy is what I like to call the emergence of new difficulties. This is one that I see more commonly in kind of middle childhood and adolescence. So maybe things have been going along pretty well academically, and at a certain point, either environmental demands change. So the academic coursework becomes more difficult, or the expectations on the child change, such that maybe there weren't any neurocognitive differences before. That is certainly possible. Or the environment wasn't really kind of revealing those differences. And now that we have higher expectations, we can see that there's kind of a breakdown in skill performance, and things that used to be not as challenging are becoming more challenging. So that's certainly a pattern that we can see. We can also see the emergence of new cognitive difficulties when the course of epilepsy changes, right? If there's a new seizure type, or seizures become more severe, or are more difficult to control. Sometimes we see these changes with medication. And then the big elephant in the room, of course, all of us, parents and kids included, have really had to adapt to some pretty significant changes in the last year and a half to 2 years with COVID. And, that I'm certainly seeing that in my clinics, where, things used to be okay with classroom-based instruction, but now there's just different expectations for children. Certainly when we were doing more virtual learning, and um, things that used to feel easy or doable are now feeling more challenging for families. So I think um, my message here is have a low threshold for being concerned about any one of these things. It can be difficult to kind of parse apart what is what, but um, at the end of the day, we want to get support for kids and families who are experiencing epilepsy. And so I think it's reasonable to talk to your provider if any of these things are happening. All right. So now I'm going to talk a little bit about how specifically we see connections between seizures and learning or academic performance. So this is an older study that took about 200 kids with newly diagnosed epilepsy and followed them over the course of 3 years. And they wanted to look at how academic performance changed over time. So they compared them to their siblings, which is a nice, convenient control. Um, and essentially, what they found is that in most academic skills, there really were not huge differences right at age of diagnosis. So, when seizures were first identified. But over the course of 3 years, particularly in reading and math, we saw that there was kind of a gap that widened between children with epilepsy and their siblings. And so we kind of have to think about why that is happening. With writing, that was one area where there were some differences very early on. So I'm going to talk a little bit about some things that might be driving some of these changes. So one of the most common concerns that parents come in with when epilepsy is something that their child deals with is difficulties with attention. So this is a big one. Attention is one of those, what I like to call very sensitive cognitive skills. So you've probably noticed if you didn't sleep well the previous night, you have a headache, you don't feel well, just about anything can disrupt attention in the brain. And seizures in particular can have a negative impact in the long term on our ability to attend. We see there's a very high rate of ADHD or attention deficit hyperactivity disorder in individuals with epilepsy. And so we tend to see estimates of, up to 40 to 60% of children with epilepsy have a dual diagnosis of ADHD. We see that children tend to have more difficulties with kind of the focus, attention, organizational skill challenge than we see kids that have, maybe what we think of when we think of stereotypical ADHD, which is kind of hyperactivity, impulsivity, those kids that really have a lot of energy, have difficulty sitting still. We can still see that. But it tends to be more of these challenges with, primary attention. And when we look at samples of children with epilepsy who have ADHD, and then samples of children with ADHD without epilepsy, we do see some distinct differences between those two groups. We see that the children with epilepsy tend to have other cognitive challenges that the ADHD alone group does not have. And so there's a lot of interesting research really looking at why this might be the case. Thinking about what came first, the chicken or the egg. There are certainly some folks who, always recall their child having difficulties in this area, and then seizures are identified and those difficulties become more pronounced. We also have some people who really noticed the onset of these things more concurrently with seizures. And so there wasn't really a noticeable problem prior to seizure onset. And now we're seeing that more significantly. So this is This is something that comes through my clinic very frequently. Um, and it's important for other cognitive skills because we need the basic ability to attend to be able to learn and encode information in a meaningful way. So, memory is another very frequent complaint that I hear um, from individuals all across the lifespan who might be experiencing seizures. And there's some general reasons for that, and there's some specific reasons for that. So, there are some forms of epilepsy that are associated with higher rates of memory challenges. Certainly, if we think about seizures that originate in the temporal lobe, which is the part of our brain that houses our hippocampus and is responsible for creating new memories and storing new memories, we see higher rates of memory challenges there. With some forms of EEG patterns, so ESES or continuous spike and wave activity during sleep. Um, some of those forms of epilepsy, we also see a stronger association with memory difficulties. But we also see that this is a challenge that many people with different forms of epilepsy endorse. And when I evaluate individuals that are complaining of memory challenges, oftentimes when we really kind of try to parse apart what is happening, memory seems to be fine. The primary memory centers of the brain are intact, but it's things like attention, processing speed, and perhaps language that can get in the way of encoding and retrieving memories successfully. So, this is something that I'm always thinking about when I'm doing a neuropsych evaluation is kind of what's driving what here. This is a very common complaint. How this all factors into learning and school performance, as you might imagine, memory, learning, thinking skills, problem solving are all really critical for every aspect of learning. Um, So, when you think about kind of the way school changes over the course of a child's academic career, kind of early on, first to third grade, we are learning how to learn. So we're learning how to read, we're learning how to write, do math, really foundational basic skills, and that sets an important foundation for other skills that we need to continue to advance. So, um, a common pattern that I see is that children with epilepsy do pretty well or can do pretty well up until third grade. And around that time, we see just changes in demand. So, we're not sort of learning the basic skills, but we're kind of integrating those skills or needing to apply those skills in a way that is fundamentally different than before. So we're not learning how to read, we're reading to learn. So we need to be able to have that basic skill to get knowledge, right? And if there's kind of a breakdown in one of these more foundational areas, it certainly carries over. And it's not impossible to catch up, but it does make it harder to handle demands like, long reading assignments or writing essays, term papers, those sorts of things we would expect from, middle school and beyond. We also, tying this back into the executive function piece, which I talked about before. So, things like organizational skills, planning, problem solving, all of those sorts of important skills are things that most kids learn naturalistically. We're not born with the ability to plan a term paper, right? We learn incrementally over time how to do that with a lot of support. If you are struggling with basic aspects of attention or working quickly or monitoring your own behavior, those tasks become increasingly challenging. And so these are things we think about when we see just higher rates of learning challenges in individuals who have seizures. The other piece that we think about are just sort of these, um, general factors that, of course, anyone who is going through, a chronic or an acute medical condition, there's fatigue associated with that. There's, seizures impact our ability to, go to school at times. And so there's just time away from active learning, whether it's due to the seizures themselves, recovery from those seizures, medical appointments. These things do, take their toll. And then, of course, there's kind of the the emotional, psychological toll of this. I work with a lot of kids who really have, understandably, a lot of concern about going to school and having seizures in front of their friends or in front of their teacher. And, um, that factors into how engaged kids are and willing they are to go to school. So these are all things you probably understand and know all too well. The last aspect of this is really thinking about the impact of seizures on the family. And I don't have to tell you that, dealing with a chronic medical condition, is a lot to handle on top of, being a parent. There's several things to consider from, the time that it takes to, ensure that your child is getting the best care medically, make sure that their needs are being met academically. I think there's also, the balance of trying to create normal expectations and opportunities for your child, while also giving them some leeway and some flexibility because there may be some things that are harder for them because of this. We also think about, the broader impact to the rest of the family. And I always like to ask families about how other siblings or other children in the family are doing, because they're a piece of this puzzle too. Um, so lots more to unpack here, but I want to keep moving. I want to share some research that has been done looking at, how epilepsy, family factors, neuropsychological functioning, and learning interact. And there's been some interesting findings that show that among children who do have neuropsychological deficits, if they come from homes that have a higher level of supportiveness, organization, and this kind of buzzword, what we like to call family mastery, these are all protective factors. So they can help kind of buffer against some of the cognitive difficulties that we see secondary to epilepsy. There's also been some work showing that, not surprisingly, when families have to, juggle multiple demands, thinking about some of these challenges, that there's higher levels of anxiety that go along with that. And sometimes those things can interact in such a way that it influences parenting and how the child is able to show their skills. So these are all really complex issues, but I think important ones to consider. All right, gonna pause real quick. Any questions, comments before I move on?
I don't see anything in the chat, but if anyone wants to unmute and just ask.
All right, I'm gonna keep moving then. All right, so I'm gonna explain a little bit about what exactly is a neuropsychological evaluation. So as I mentioned before, oops, sorry about that. um, This is an evaluation. We are looking at brain functioning in an indirect way. We don't use EEGs or brain scanners, but we do use kind of what I like to call brain games, paper and pencil tests, looking at puzzles, pictures, remembering things. Some of this testing can be computerized. So we look at several different domains of cognitive functioning, but we also think about the larger context. So things like emotional and behavioral functioning, what family functioning looks like, etc. Some of the referral questions that come to me for children with epilepsy is, wanting to understand what those cognitive strengths and weaknesses are, what we can do to help. Oftentimes, there are questions, sometimes about a specific diagnosis, like is this person struggling with ADHD? Is this person struggling with a learning disorder, etc.? Some of the children that I see are being evaluated for epilepsy surgery. And so there's kind of some more specific testing that we might do around that. And then for individuals that are closer to kind of adulthood, kind of at that 16 and 17-year-old age range is when we really want to start thinking about that transition to adulthood and what that looks like and how we can set adolescents up for success there. So what you can expect from neuropsych, I'll be quite honest that it is a long day of testing that can either be done in a single session or spread out over multiple days. We do a lot of interviewing of parents and children. We do testing. We do review of records. If you are someone who's interested in doing this, I would plan to schedule this as soon as possible if you're looking into getting academic supports like an IEP plan. And how often, it's kind of up to you and to your medical team. I would say as often as you feel is necessary. So if there are, new changes, new concerns, or if your child is going through one of those transitional periods, so end of elementary, end of middle, end of high school, and you want to think about next steps, those are perfectly reasonable times to be doing this. These are just some of the many areas that we might attempt to sample when we are doing cognitive testing. And so there are several different pieces to the puzzle. The way that we want to use this information, what's the purpose of all of this? First, usually I am trying to address, are there medical or neurological factors that are contributing to some of the challenges? How can we help with learning? How can we use some of your child's strengths to kind of help compensate for the things that are more difficult? And thinking about the level of support that is needed to help your child reach their potential. So at the end of this is, sorry, I'm having some connectivity issues. I'm going to try to fix on my computer real quick. Usually what we would do is sit down and do a way. So try to be as specific as possible. So for instance, if a child is struggling with attention or with slow work pace, we might recommend things like preferential seating, putting them in a part of the classroom where they're going to have increased touch points with a teacher, giving them more time to complete work, reducing the workload. If your child is one that has difficulties with their fine motor, their writing skills, we can see that a lot in certain forms of epilepsy. It might make sense to reduce some of the demands of handwriting in the classroom and to think about assistive technology. So speech to text, getting outlines from the teacher, recording lectures. These are just some other examples of some tailored recommendations we might give depending on areas of challenge. And in the last couple of minutes, I want to give you a brief overview of the menu of supports that are available. Primarily, I'm going to be talking about public schools, but some of these things are applicable to private schools and charter schools. So an individualized education program plan, or an IEP, is a program, it's a federally funded program that children with a defined quote unquote disability are eligible to get if they meet certain criteria through the school. So the school determines if a child is eligible. Medical professionals and psychologists can make lots of strong suggestions, but ultimately it is up to the school. I will say that epilepsy is a medical diagnosis that most schools tend to recognize as being, an important one, and one that often comes with IEP supports. That's most of the time, but there are exceptions to that. The school is really kind of looking at, does this condition impact the ability of the child to learn solely from general education curriculum, so without any supports? And so if the answer to that is yes, that impacts their ability to learn, we might think about some comprehensive supports that would be needed to kind of assist that child. There are 12 categories of eligibility. I won't go over all of them, but I do like to mention other health impairment because it is the most common one where children with medical conditions, including epilepsy, might get support under. A 504 plan is kind of a cousin of an IEP. It's a little bit different. This is part of the Americans with Disability Act legislation, and it isn't tied to federal funding in the same way that an IEP is. They're really looking to see if there's a physical or mental impairment that limits that individual's ability to participate in school. And so it's the bar is a little bit lower for getting a 504 plan. And just because of the way they allocate resources and define kind of criteria for this. So side by side, thinking about these things, sorry. So an IEP, you need really, there's a higher threshold, excuse me, there's federal dollars that are tied to it. It's a little bit more structured in that it's a team of individuals through the school that are meeting on a annual or 3-year basis to evaluate that child's progress in areas of specific goals that are set. And it can really include quite an array of supports, from accommodations to modifications or changes in curriculum, things like speech pathology, occupational therapy, those sorts of things, whereas a 504 plan is not as comprehensive. So if you are interested or think your child would be eligible for this, if you haven't had a neuropsych evaluation, I would talk to your neurologist or talk to your primary care provider. The important thing to consider with either one of these plans is always put your request in writing. So you want to go to usually the principal of the school and request that your child is either evaluated for an IEP, where they will start to determine if your child is eligible, and that process can take several months and may even take longer, given some of the backups we are seeing with COVID. Then it's a very similar process for a 504, but it's not quite as lengthy. I'm going to share some resources with you for navigating the IEP process. Essentially, there's a lot of tools and tricks. I can't get into all of them today. Fact Oregon is a wonderful resource. Even if you are living in Washington, it is a website. They're a nonprofit, and they offer, quite a bit of education for parents, free information about just educating yourself about special education law, which is the umbrella all of these services are housed under. Kind of what your rights are, essentially. I think it's important to highlight that you really think about this. I think there's a lot of sort of adversarial things that can come about when you are advocating for your child to have the supports that they need. And that can often be at odds with maybe how the school sees your child or the resources that they have to offer. And so that's where getting support from your medical team, from your neurologist, your neuropsychologist can really be helpful. I do think it is important just to keep in perspective that, even though we do these lengthy evaluations, we are really only getting a snapshot of your child. Teachers in schools are kind of, seeing the day to day. And so I think it's important to really come together to work as a team to figure out what are the supports that are going to be needed for your child. If you don't get what you ask for, you have quite a few resources. I would, in addition to FACT Oregon, the website Rights Law is not specific to any state, and these IEP laws, most of them are federal, and there are some nuances state to state. So Rights Law is a good resource. I think the other thing to keep in mind is with these accommodation plans, they can help a lot, they can help a little. The goal of the plan is not to kind of return anyone to kind of what functioning was like before epilepsy. I think that is a difficult task. I think sometimes that is possible, but it is not always possible. And so think about school as one piece of the puzzle, and don't be afraid to utilize supports outside of school. So I think that's where talking to your doctor and your team about other things that might be helpful, sometimes therapy, sometimes outside tutoring, sometimes things like medication for attention are things worth considering if we've tried quite a bit in school and we're still not seeing the improvement that we would like. Life after high school, I just want to put on everyone's radar that these plans look a little bit different. IEPs do not continue into the college environment, but 504 plans do. If you are starting to look into colleges, an important thing to do is really kind of get a good sense of what the learning supports would be like at that campus. And talking to the Student Learning Center or the Disability Center is sometimes what they're called, about kind of some of the supports that might be in place is really going to be critical. I think, remembering that, well, let me see here. Yeah, the other piece I wanted to mention is that for some individuals, maybe those that are getting higher degrees of special education or a modified diploma, in the state of Oregon, they are eligible for what's called transition planning, which begins at age 16, where you really are sitting down with the school and thinking more about what does life after high school look like, whether that's, a shift from academic learning to more vocational training and adaptive skill support. And then some schools do offer extended schooling through the age of 21, if that's something that your child would benefit from. I want to just leave you last with some other supports. The Epilepsy Foundation has some great information about scholarship options that